Time for another Puscast, brought to you by the growing multimedia empire of edgydoc.com. You can find the references to this podcast as well as links to my growing multimedia empire over at the aforementioned edgydoc.com. This Puscast is covering the last 2 weeks of December 2014, but is the first podcast of 2015. You know, I've been doing these since 2006. I think I started July 2006. So I've been slogging away at this for a long time. I hope you have learned as much as I have. But enough of this. Let's move on to the literature, shall we? I know everybody has been wiggins about Ebola of late. But really, Ebola is not going to be that big a deal in the industrialized nations. However, keep an eye out for dengue. And a recent report from the United Nations found that dengue, which causes breakbone fever, is getting primed to infect large parts of Europe, West and Central Africa, and South America. And dengue is right up along the U.S. border with Mexico, and there have been cases in Florida. So I'm not too worried about Ebola. But dengue, we got the mosquitoes, we got the global warming, and once the mosquitoes get in and infected in an urban area, they should take off quite nicely, as the outbreak in Japan's park in Tokyo has demonstrated ever so well. Don't worry about Ebola, worry about dengue. And then who knows what things are actually already in the United States. For example, there's this new bourbon virus that's been discovered in Kansas. It killed somebody in that state. The bourbon virus caused fevers, low red cells, low white counts, transaminitis, and appears to be tick-borne, or they're not certain if that's the case yet. It looks like it's an orthomyxovirus, and it's similar to viruses found in Eastern Europe, Africa, and Asia. What it's doing in the Midwest is yet to be determined, since most of the interesting things in the United States are on the coasts. But whether this is an import or a new virus that is now settling into Kansas is yet to be determined. But you'll be looking one way at Ebola, and you'll get smacked upside the head looking another way by dengue or bourbon virus. By the way, it derives its name from the county in which it was discovered, Bourbon, and not the ever-so-delicious drink. I wonder if I drank enough bourbon if I could kill off the bourbon virus. I mentioned a while back that they finally found a use for ribavirin, which is the treatment of chronic hepatitis E. This tends to occur in patients with underlying immunodeficiencies such as organ transplants. In a study where they treated 24 patients with chronic hepatitis E, they found that those who continued to shed hepatitis E in their stool despite the ribavirin were those who suffered a relapse. So that might be a way to determine whether or not these patients are going to respond to the ribavirin. Interestingly, those who did continue to shed the hepatitis E in their stool were negative when their blood was tested. So the presence, or I should say absence, of hepatitis E in the blood does not necessarily mean that you are going to get a ribavirin result, and it may be the stool studies that are more important. And a more important question, which was not addressed in this study, is why did they continue to secrete hepatitis E in the stool? And why did the ribavirin fail? Was it the host? Was it the pharmacokinetics? Was it resistance? That is as of yet to be determined. I am a big microbiome fan. I think it's a fascinating topic. It has long been hypothesized that part of the ongoing inflammatory response of HIV disease is due to ongoing viral replication. In this study, what they did is they took a bunch of HIV patients on retroviral therapy and another bunch of normal people, and they found there was a marked difference in the microbiome between the HIV infected on heart and the HIV uninfected patients. There was a variation in a variety of classes of organisms that I will not even pretend to be able to pronounce. As a consequence, there was difference in both bacterial translocation and levels of various and sundry cytokines. It was a small exploratory study, but would suggest that part of the reason for the ongoing inflammatory response that we see in HIV patients, and perhaps the subsequent vascular events we see as a result of that inflammation, may be due to changes in the microbiome of the gut, as well as increased microbial translocation and a resultant increase in inflammatory markers. As I've said before, perhaps what we all are actually is sentient transport and feeding mechanisms for our bacterial microbiome. We really are pod people and should bow down to our microbial overlords. So, I don't get the flu, so I don't need to get the flu vaccine. So goes the excuse one hears so often. But part of what you need to know is what is the attack rate of influenza in an unvaccinated population. You're not vaccinated. You're not 100% going to get influenza, either A or B. So this study went and looked at 30 years worth of influenza clinical trials for laboratory confirmed influenza and looked at the placebo group and asked, what was the attack rate of influenza? Across the board, the attack rate in adults was 3.5% for all influenza. Remember, this is laboratory proven. 2.3% for influenza A and 0.59% for influenza B. The attack rates are actually pretty low in adults. For children, however, it's much worse. The overall attack rate was 15.2%. For A, it was 12.27%, and for B, it was 5.5%. So adults probably have a lot of residual immunity from the real influenza they got as children and prevents them from getting disease when they're adult. That's what I would bet anyway. But it is interesting to note that the attack rate for influenza in a given flu season isn't that high. So yeah, you're unlikely to get influenza even if you don't get the vaccine. That's not, however, a reason to avoid the flu vaccine. But there's more on that topic over at Science Based Medicine. As I do this podcast at the beginning of 2015, the influenza hospitalization rates are about double what they were last year. So we're heading into a bad influenza season, and in part it's because we have a new strain of H3N2 influenza circulating. There's both a new strain, and the old strain that's in the vaccine has drifted. Therefore, people have said, I don't need to get the flu vaccine because it's no longer covering my influenza that is in my community. Well, yes, but no. It still gets influenza H1N1. It gets influenza B. It gets about 40-50% of H3s that are circulating. So it only misses about half of the H3s that are circulating. But more importantly, and this is a very interesting thing about flu vaccine, that there is suggestion that even when the flu doesn't match well in the vaccine, you still generate antibodies that can be cross-reactive with circulating strains of influenza. Remember that within the flu antigens, there are those that are very specific for the circulating strains and those that are more broadly active against other strains of influenza. So they looked at a bunch of people that were exposed to bird flus, and they were exposed to H3s, H4s, 5s, 6s, 7s, 8s, and 12s. And they found that in people that were exposed to bird influenzas, that they also developed broadly neutralizing antibodies against other strains of influenza, including the H3 that's wandering through the United States right now. So some of the antigens that are found in the vaccine may generate antibodies that are broadly active against other strains or other epitopes of the influenza virus. And so you may still get some protection, and does explain in part why, even in years when there is a poor match between the vaccine and the circulating strains, there is still efficacy from the vaccine. It's just not as good as when you get a better match. I like car metaphors. Usually, the flu vaccine is seatbelts, front and side airbags. This year, because of the mismatch, we still have the seatbelt, we still have the front airbags, we just don't have the side airbags. And I would just as soon head into the flu season with as much protection as I possibly could, especially since H3 strains may have increased risk of vascular events like heart attacks. Infections and vascular events. Have you heard that theme before? Do I keep harping on that over and over again? Should I mention the European Journal of Neurology published a study called Previous Infection and the Risk of Ischemic Stroke in Italy? And what did they find? They found that if you had a recent infection, your probability of an acute ischemic event went up. Relative risk 3.692. I know. Infections are inflammatory. Inflammation is prothrombotic, and prothrombosis leads to vascular events. Don't get infected. It will only lead to a stroke. There is, understandably or not, a U.S.-centric approach to this podcast, mostly because I practice in the United States. But I do like to travel. And I hope to be traveling more as I get older and get to head into retirement. How common is antibodies to Borrelia burgdorferi in Germany? There's a lot of Borrelia in Europe. And occasionally I see patients who've traveled to that part of the world and fret that they have picked up their Lyme disease in Europe. It turns out to be fairly common in Germany. The seroprevalence in women is 5.8% and it's 13% in men. And the longer you live in Germany, the more likely you are to be seropositive. So the infection risk is highest in the elderly. So when thinking about Lyme disease, don't think just about the American Northeast. Consider Europe as well. Burkholderia or Burkholderia pseudomallii is the cause of melioidosis found throughout Southeast Asia. There have been a smattering of cases in the United States over the years. It is interesting that they looked at the incidence of melioidosis in Singapore and found that it was associated with increased rainfall and humidity. So like Legionella, this is another infection that is associated with what I would call thundershower weather. Now, in the United States, we have no endemic melioidosis, at least at present. But one of these days, if we're unlucky, it may get here like, that bourbon virus I was talking about. Who knows? Maybe it'll be one of the diseases we will acquire with global warming. There was that case in Arizona in 2011 that they could not find a source for, and so evidently was acquired in Arizona from Arizona. At least humid rainfall is not what I consider Arizona to be known for. There's a nice review on the microbiota of the colon and how it relates to obesity in the New England Journal of Medicine. I wish I had a little less ethics because I think I should write a textbook, or actually a cookbook, The Microbiome Diet, and make a fortune. But that's not in my future. I'm sure someone else is doing it even as we speak. However, there's now a preliminary study using poo pills, i.e. oral capsulized frozen fecal microbiota, for treating C. difficile. It was published in JAMA and is probably the future of treating C. difficile. They only had a small number of patients with relapsing C. difficile, 20 in all, but with the first pill, 70% got cured. Then the non-responders got retreated, and 4 had resolution of their diarrhea. So that 90% were cured with poo pills. Now, if you could just combine them with a weight loss microbiota, you could cure the C. difficile and lose weight. Genius, I tell you. We tend to think of respiratory syncytial virus as a childhood disease. I note that when we get our flu report from the lab, they also give an RSV report, and RSV is also going gangbusters in the community right now. RSV, however, is a disease of adults with not inconsiderable morbidity. This was a retrospective study, and they identified 86 patients with RSV infections over this time period, with 15% requiring ICU care, 9% requiring ventilatory support, and 6% dying. That's a pretty significant morbidity of RSV in the adult. Interestingly, that was a non-specific presentation, as are so many viral infections, and often they were treated with antibiotics and or anti-influenza therapy for what was actually an RSV. This will probably change in your lifetime if you're a youngster listening to this, because now we have these respiratory panels that allow us to much more rapidly diagnose a broad number of respiratory pathogens. And I remain amazed at the number of bugs that show up on these panels on patients in the ICU. So RSV is likely to be on the list of causes of respiratory illness in the elderly and adult population. And the treatment we have for RSV, at least in kids, costs an arm, a leg, and your firstborn male child. So empiric therapy is not going to be high on the list. So I don't know if this is a case in my microbiology lab. I'm going to have to check this out on Monday. But they looked at the causative agents of infections in dog bite wounds. And they found that an organism found in dogs' mouths, Staphylococcus pseudointermedius, can be misidentified as Staph aureus. You may say, who cares? I do. Knowing the name of the organism allows you to better understand its epidemiology and to kill it. It is important, if nothing else intellectually, than to specifically know the bugs it is you're killing. Sometimes, I suppose, just to be a butt, or perhaps to make people focus, when I get a consultation, I ask the house staff to give me their question in 5 words or less. It's amazing how often they can't do it. Why fever is probably the simplest of the consultations I get. And this looked at ICU patients who had persisting fever after they had therapy started for sepsis. If you have a diagnosis and you get appropriate antibiotics, you may continue to have fever and it's not associated with increased mortality. However, if you come in and you do not have a diagnosis that is being appropriately treated by your antibiotics and your fever persists, that is associated with an increase in mortality rates. So fevers persist in the ICU once you're put on appropriate antibiotics. And if you're on appropriate antibiotics, i.e. the bug you are growing is killed by the antibiotic you have the patient on, prolonged fevers is not as worrisome as if you don't have a diagnosis. The patient is on antibiotics and the fevers persist. Those are the patients who have increased mortality. I think the take-home from this particular study is if you have the right diagnosis and the patient's febrile, tough it out. If you don't have the diagnosis and they're febrile, keep looking. And perhaps with, an infectious disease consultation. I recently had a case of a renal transplant patient with pulmonary and cerebral abscesses who had a very positive 1,3-beta-D-glucan. So I went running down the fungal pathways trying to figure out his diagnosis, and eventually a diagnostic biopsy yielded nocardia. I subsequently found 2 papers in the Japanese press, both case reports, where nocardia also causes a positive 1,3-beta-D-glucan, aka the Fungitel. I wrote those up for Medscape. Now there is a study called Cross-Reactivity of Nocardia Species in the Fungal 1,3-beta-D-glucan assay performed on cerebral spinal fluid. So here's a 4th report. I don't think you count mine in Medscape, but another report of Fungitel being positive for nocardia. So put nocardia on the list of things that'll give you a positive 1,3-beta-D-glucan. Treating nocardia is very different than treating Candida or Aspergillus. Duh. When I think of caseating granulomas, I think of tuberculosis. This turns out not to necessarily be true. This study looked at the pathologic findings on biopsy in patients with tuberculosis who did not have HIV. And it's interesting. The pulmonary tuberculosis patients, 20% had chronic granulomatous inflammation, and 3% had concomitant caseating necrosis. So not everybody had the classic findings of tuberculosis. And they found that just on the basis of necrosis alone, you could make the diagnosis of tuberculosis. But not every patient in the study who had biopsy-shown tuberculosis actually had the classic caseating granulomas that you associate with tuberculosis. So be wary about the pathologic diagnosis to exclude tuberculosis if it's not classic. And I'm going to finish off here with a bunch of hodgepodge, mostly epidemiologic information, because in ID we love epidemiology, and a couple of clinical trials that are mostly negative that only deserve a one-liner. So this will just be a hodgepodge of interesting things. One, in Switzerland, free-ranging mice, which I prefer over free-range chicken, were found to have Francisella tularensis, tularemia, and it did not, however, infect human beings. There's also an increase in tularemia in Sweden, and it's mostly found in the areas with lakes and rivers. They're having a huge problem with tularemia in that part of the world. They're also finding it in rabbits, and they have hair-to-human transmission of tularemia in Germany. But I guess it's not spreading the Lyme disease at that point. There's an ongoing outbreak of pneumonic plague in Madagascar. So don't inhale when you're in Madagascar. There was an outbreak of cryptosporidiosis in what? People who responded to a truck that was carrying calves. The calves rolled over and people got cryptosporidia from the calves, and that animal is referred to as the scours. Ooh, that must be one nasty kind of diarrhea. Streptococcus equi, subspecies zooepidemicus, is associated with guinea pigs. There's been an outbreak of listeria throughout the United States that's been associated with caramel apples. There's been an increase in milk-associated outbreaks, all from unpasteurized milk and predominantly Campylobacter. You really have to be stupid to drink unpasteurized milk. It's not more healthy, but it is a source of infections. And always remember that the cow's udder is, by way of gravity, right underneath the cow's butt. So when you drink unpasteurized milk, you're drinking cow poo. There was a fatal case of Legionella in a baby who had a water birth and who went on to develop pneumonia from Legionella and died. There's an ongoing association between diabetes and tuberculosis, and so as our population gets older and fatter, they're also at increased risk for diabetes. And a couple of relevant clinical trials. They're still trying to figure out whether or not steroids work with septic shock. In this study in critical care medicine, low-dose corticosteroids did nothing in terms of outcome. Daptomycin is probably worse than linezolid for treating VRE bacteremia. Coccidioidomycosis is now found in Washington State. To my mind, it's Washington. There's Washington, D.C., and Washington, but there is now cocci found throughout the soil of Washington State. And we end with predictors of iris and organ transplant patients, and interestingly, one of the variables in a transplant patient for developing iris is discontinuation of their calcineurin inhibitors. And that ends are hodgepodge of risk factors for infectious diseases. Don't be an obese caramel apple eater in Washington state who gets their calcineurin inhibitors discontinued. So that's the end of this Puscast, covering the last 2 weeks of January 2014. Don't forget to go to my growing multimedia empire at edgydoc.com, where you can find links to all the wonder that is me. Also, write me glowing reviews on iTunes, and above all, please check out the Society for Science-Based Medicine. Otherwise, thank you for this consultation and allowing me to participate in the care of this most difficult and challenging case. I shall continue to follow along with you. Thank you. In dictation, goodbye.